the topic that we have chosen. Can we start?
Yes, sir, we can start, sir.
Okay. So the topic that I have chosen today is surgical obstructive jaundice, imaging in confirming diagnosis and treatment planning. Now, it's important that this presentation presupposes that we have a patient of surgical obstructive jaundice. We have taken a good history. We have examined this patient, and now we are sort of confirming the diagnosis. So it means that the diagnosis of SOJ or surgical obstructive jaundice is confirmed. Now, what is surgical obstructive jaundice? I think we've been talking about surgical obstructive jaundice all this while, but it should be that those entities which can be uh, managed with a surgery is generally considered to be surgical obstructive jaundice. Having said that, not all the patients would be amenable to surgery, and overall, the obstruction will be to the extrahepatic biliary tree, starting proximally at the hilum and distally all the way up to the ampulla of water. So if there's an obstruction in this line, there is extrahepatic bile duct obstruction, and this extrahepatic bile duct obstruction lends itself to surgical management. So now we have an obstructive jaundice patient. History has been taken, some basic biochemical tests have been done. So now we have to confirm his diagnosis and then plan the treatment. Now, this exercise that we are undertaking today will only talk about treatment planning in the basic concept, not the treatment planning in detail about each and every entity that we'll be talking about. Now, one important diagnosis is CBD stone, and we should know what is the essential workup. So, the diagnosis of CBD stone is done on the basis of clinical context. Now, here you have a patient who's got obstructive jaundice, who's got symptoms of biliary colic, and he may have cholangitis or he may not have cholangitis. Now, in the patients of CBD stones, generally the jaundice doesn't go very high up. And as we discussed in our last class also, it's because the fact that CBD stones generally give rise to partial obstruction. So you would have jaundice in the range of anywhere between 2 to 5 or 6, but generally it doesn't go and beyond 10. If jaundice is at the level of 10 or conjugated bilirubin is at the level of 10 milligram percent, one should think in terms of a malignant obstruction. Now, what gives away the diagnosis? If you have done an ultrasound examination, and which I think every patient of CBD stone, as we discussed last time, every patient of CBD stone after the basic blood works should go in for the ultrasound examination. And if ultrasound shows stones in the gallbladder and there is no mass in the gallbladder here, we are talking about the stones. The gallbladder may be thickened, gallbladder may be having some perforation, gallbladder may have some stones in it. So these are the kind of things. If there is, of course, any finding suggestive of a mass lesion in the gallbladder, that's a different thing, and we will talk about this in our later presentation. So what you find is stones in the gallbladder. Stone in the gallbladder with obstructive jaundice is generally a giveaway diagnosis. Please be quiet. Is a giveaway diagnosis for CBD stone as the cause of obstructive jaundice. And what would you find on the ultrasound? You'll find that the ducts are dilated, and you may be able to see the stone in the bile duct. Now, remember, being able to see a stone in the bile duct is not an essential criteria. It is plus minus. CBD stone is a must, and dilated CBD with stone or without stone. Generally, because of overlying gas shadow, at times the stones in the distal CBD may not be visible. So that doesn't mean that the diagnosis is not CBD stone, but the stones could not be visible here. And that's generally the way, we look at a patient with a possible or probable diagnosis of CBD. Now, in equivocal situation, when you are not very definitive of your clinical context, you can always get more information by way of magnetic resonance cholangiopancreatography, MRCP, or endoscopic ultrasound. So these are things which can give you further confirmation about your diagnosis, and that is only to be applied in equivocal cases and not in all cases. ERCP can be done only for therapeutic intervention. So in today's time, ERCP is only pressed into service when we are looking for some therapeutic situation, like in a patient of cholangitis with sepsis, we want to drain the biliary tract, or we were planning to do this removal of the stone by papillotomy. So in this situation only, ERCP, since it is an invasive investigation and since it has some complications associated with it, is not applied in the run-of-the-mill situation. It's only applied only when we are looking at the therapeutic. If we are looking for confirmation, then MRCP or endoscopic ultrasound are the test that we would be pressing in this situation. Now, once we know that the diagnosis of CVD stone, then the next thing is what to do about this patient. If gallbladder is present, and there would, as you would have discussed number of times, there are multiple approaches. So you can do first CVD stone extraction by way of endoscopic papillotomy and stone retrieval, or you can go in for surgery and do a colidoco removal of the stone by laparoscopic bile duct exploration. So these are options which will be available. Another option could well be, which is of course not very common, and that is first you do a lap chole, and subsequently on second or third post-operative day, you can plan this patient for ERCP. But the preferred approach always is to clear the CVD and then go in for doing laparoscopic cholecystectomy. In a situation if we do laparoscopic cholecystectomy and leave further stone removal on the second or third post-operative day, and if we are not successful, then it is, I think, suboptimal, and patient is not comfortable with that option. So either you go in for a extraction of the stones by endoscopic method preoperatively, or you go in for laparoscopic CBD exploration, either direct laparoscopic exploration or through the cystic duct, depending upon the context. So that is how we should look at the CVD stone. And as I mentioned in my previous class also, in where the stone, in patient where the CVD stone is a cause of patient's obstructive jaundice, gallbladder will generally not be palpable, and this is in accordance with the Courvoisier's law, except for what we discussed that time, double impaction. And I think we'll not go further into it. Next entity that we have is bile duct stricture. Now, what is the clinical context where you will suspect that the patient is having a bile duct stricture? The clinical context in this situation would be previous surgery. If a patient has undergone surgery in the past and has subsequently developed obstructive jaundice, and if this jaundice is also associated with features of cholangitis, then I think there is a strong suspicion that the patient is having bile duct stricture as a cause of his obstructive jaundice. Now, how do we confirm the diagnosis? Again, the confirmation comes by way of MRCP or ERCP. As I mentioned previously, ERCP should not be pressed into service for diagnosis on the drop of the hat. It should only be done when other options are not available. Now, when we have a patient where we are having a suspicious of bile duct stricture, and ultrasound has given us the idea. And what is the idea that an ultrasound will give here in this context? Patient will have obstruction at the level of the stricture, and there will be proximal dilatation, and the distal bile duct may not be visible. So that's the kind of information that we'll get. And of course, this will also mean that there is no mass lesion in the bile duct per se. Otherwise, we would be probably dealing with cholangiocarcinoma. So that will always remain as a differential diagnosis in this situation. How do we know? And as you all know, whenever there's a bile duct stricture, we have to know the type and the level of bile duct. stricture. So by way of doing an MRCP or PTC, we should be able to understand uh, percutaneous transhepatic cholangiography. That is what PTC stands for. And PTC is generally these days not needed because all other armamentarium is good enough to tell us about the site of obstruction. Uh, no, here we are also very important. When patient develops a bile duct stricture, there is always a possibility that at the time of injury, there might have been some injury to the hepatic artery or the portal vein. So we should always look for any sign and any feature of any vascular or associated biliary injury. For example, there could be an injury to the right hepatic artery, which may result in atrophy of the right lobe of liver, or there could be an injury to the accessory right anterior or right posterior duct, which may result in atrophy of that portion of the liver. So I think understanding the vascular injury is also very important. When we have an idea about the level of stricture, and that gives us the idea, that gives us the tools, to sort of grade the bile duct stricture along the this bismuth grading system, and that is how much of the this bile duct is available below the confluence, whether the confluence is intact or where the confluence has been injured and the two right and left systems have separated. That all information needs to be available so that we can plan our surgery accordingly. So this is all that you need to know as a PG exam going student. Beyond that is something which is not really in the scope of this presentation today. Now, there is one important condition that comes in mind, and that condition could be thrown up to you in as a scenario in the exam. The Mersey syndrome. Now, what is Mersey syndrome? I show you what is Mersey syndrome. Now, Mersey syndrome is when there is a stone in the neck of the gallbladder and it is causing pressure on the common hepatic duct. And it's been shown that there are two classifications. One is McSherry's classification and another is Sineda's classification. And you can see this diagram this is the normal situation. In type 1, there is the stone which is causing pressure on the common hepatic duct. In type 2, there is a fusion of the gallbladder wall and the common hepatic duct wall. And in grade 3 of Sineda's classification, there is erosion of the wall of the bile duct and half of the circumference is gone. And in the next grade, that is grade 4 or type 4 meninges, in this there is 2/3 or more than 2/3 destruction of the common hepatic duct wall. Now, why do we need to know it and what can help us know it all? I think it's whenever we suspect that there is a large stone in the gallbladder, which is causing pressure, which is giving rise to obstructive jaundice, I think we need to press into service a modality which can tell us what is happening to the extrahepatic biliary tree. And in this region and in this context, what will come in handy is an MRCP. MRCP can give us a very good idea. And why do we need it all before surgery? Because type 1, type 2 can be nicely managed with cholecystectomy without altering much of the approach. Type 1 will be simply uh, same laparoscopic cholecystectomy that we have been doing. In type 2, we may need to leave behind a little bit of a cuff of the Hartmann's pouch so that we don't cause any injury, because as I mentioned, there is the gallbladder wall and the common hepatic duct wall, they have become fused. So leaving behind a part of the gallbladder is something which will help us save the injury to the bile duct. In type 2, again, this is a kind of an overlap zone or borderline area where you can either do a subtotal cholecystectomy and extract the stone. Every time around the stone has to be extracted, and extract the stone and sort of leave behind a cuff of the gallbladder and close it. Or if, type 4 generally would require an open approach and hepatico-jejunostomy. So this is why it is important for us to understand what kind of a uh, Mirizi syndrome, what type of Mirizi syndrome our patient is having, and plan the treatment accordingly. I'll repeat: type 1 laparoscopic cholecystectomy by and large the same way as we do in a routine situation, and try to dislodge the stone which is present in the bile duct, which is present in the neck of the gallbladder. Type 2 would require leaving behind a cuff of the gallbladder and removal of this stone. And type 3 would require, again, the same approach can be done, which we have done for type 2, or we can go in and do an open cholecystectomy and do what is known as cholecystocholidocoplasty. And type 4 would generally require hepatico-jejunostomy. So that's the way we look for management of Mirizi syndrome. And this is something which could be a discussion in a patient of obstructive jaundice when you find that the gallbladder is not palpable. And I again repeat, the patients of Mirizi syndrome with obstructive jaundice will generally not have a palpable gallbladder. They will not have a palpable gallbladder, and the obstructive jaundice would be at a level of about 2 to 5 milligram percent of conjugated bilirubin. So that's what you need to know about. Mirizi syndrome. Now, another entity that comes in the picture is choledochal cyst. Now, how do you suspect that the patient has choledochal cyst as a cause of his obstructive jaundice? I think age of the patient is very important. In a younger age group patient with obstructive jaundice, and younger would mean, generally we would not have a pediatric patient coming to us, but anybody in the teens, and he presents to you with obstructive jaundice, that's one thing that you should look at. Second is if the patient has a palpable lump and associated with cholangitis. So three things: age of the patient, a palpable lump, and cholangitis should give you an idea that you may be dealing with a patient of choledochal cyst, and which would have been reinforced by ultrasound examination. Now, you have to confirm this. And how do you confirm it? I think in today's time, the important test that should be done in all patients of choledochal cyst is MRCP. MRCP will tell you what type of choledochal cyst the patient is having. And based upon that, you can plan your treatment. Now, there is one entity which is called as abnormality or aberration of pancreatico-biliary junction and occurrence of CA in the choledochal cyst. Now, if we are looking at these things, then we probably will require CECT and maybe endoscopic or ERCP. So this abnormality of pancreatico-biliary junction and CA of the cyst, choledochal cyst, are two situations that can be present simultaneously or concurrently in choledochal cyst. So if somebody asks you about concurrent pathologies, the one is abnormal pancreatico-biliary junction, and the second is occurrence of a CA in the choledochal cyst. And if your patient is having, progressively increasing obstructive jaundice, you have to suspect choledochal cyst carcinoma. And it is a function of abnormal mucosa of the choledochal cyst and the duration for which the cyst has been present. So as you all know, the treatment of choledochal cyst is removal of all the mucosa of the choledochal cyst, so that subsequently the patient doesn't have choledochal cyst associated carcinoma, which is a variety of a cholangiocarcinoma. Now, so these are the various types of choledochal cyst. Type 1 is a fusiform kind of dilatation of the bile duct. Type 2 is kind of uh, focal dilatation, as it's shown, is kind of an outpouching. It presents like another gallbladder-like thing, And type 3 is this choledococele, where there is, uh, narrowing at the junction and results in dilatation of the choledochal seal. This results in the results in results in dilatation of the this ampulla, and sometimes this ampullary mucosa has a tendency to prolapse into the opening. So this is type 3. Type 1 is fusiform, type 2 is secular, type 3 is choledochal seal, type 4 is uh, type 4 is a fusiform dilatation with dilatation of the right and left hepatic duct, and type 5 is mostly intrahepatic, and it spares the main bile duct. So I think on the basis of MRCP, you should be able to differentiate between the various types of choledochal cyst. Type 1, fusiform. Type 2, secular. Type 3 is choledococele. Type 4 is dilatation of the bile duct, and secular dilatation, multiple saccule formation of the right and left hepatic duct. And type 5 is mostly intrahepatic, and it spares the main bile duct. So these are various types of, and it's also mentioned as Caroli's disease. Now, the treatment is radical excision of the choledochal cyst. So you have to excise all the cyst, and you have to ensure that you will go all the way down, but make sure that, in patients of abnormal biliopancreatic junction, you have to make sure that that kind of abnormality is not happening, or else it can result in obstruction or an injury to that APBJ, and which can be disastrous. So we generally see that at the level of the upper border of the pancreas, where we can clearly identify this narrowing down into the retropancreatic part of the bile duct, that's the level up to which we excise. And sometimes we have to excise whole of the confluence also, but most of the time we remain below the confluence, and it is the confluence which is anastomosed with a Roux-en-Y loop of the jejunum. And but if of course this dilatation is extending into the right and left ducts, then you have to excise right up to the point where it is normal, the junction of the normal, and then make the anastomosis with the Roux loop, with which may require two hepaticojejunostomy, one for the left, another for the right, or maybe even three, one for the left, and right tends to separate. So right anterior and right posterior may need to be anastomosed with the Roux loop separately. So that's how you would attempt the treatment of choledochal cyst. It starts with a proper diagnosis, and then managing according to total excision of the choledochal cyst mucosa. And at times, when you find that this is not achievable because of long-standing long-standing inflammation, at that point, what are the options available? At that time, only option available is either removing as much part of the mucosa as possible and leaving behind some mucosa posteriorly, or doing so that is a second operation, and that is probably known as Lily's operation, which is of course nowadays hardly done. I have not seen anybody do it. But if you find that there is a risk of injuring the structures behind the choledochal cyst, then you can think of leaving behind some posterior mucosa and doing the anastomosis with the rest of the choledochal cyst. And the other part is, which can be done, other operation that can be done, is choledochocystojejunostomy. This is an inferior operation and has a chance of developing both strictures and also a complication of carcinoma in the choledochal cyst. So whenever possible, radical excision is the treatment of choice. and other operations can only be done in some situation where the treatment, radical excision is not possible. So that's all that you need to know about choledochal cyst. Now, other entity that we come across is cholangiocarcinoma. And cholangiocarcinoma, here we are talking about cholangiocarcinoma at the proximal biliary tract, that is in the region of the hilum, right? Or what we have been referring to as Klatskin tumor. So that's one entity which is quite important and is responsible for obstructive jaundice in quite a few patients that we may see in our exam. Now, how do we suspect that the patient may be having um, cholangiocarcinoma at the hilum, or what's called as Klatskin tumor? Uh, you would find that um, whole of the bile duct is not visible, and intrahepatic biliary channels are dilated, and there is a mass lesion sitting in the confluence of the bile duct, confluence of the ducts, or there is a mass lesion in the bile duct per se. So when you have that kind of a picture on ultrasound in a patient who is in the cancer age group, that's 55, 60 plus, and is having a jaundice which is increasing, which is having rising to 10 and 20, that's the kind of thing. Patient is having a poor Karnofsky scale. So this would be another thing, that your older elderly patient with poor Karnofsky scale, having deep jaundice and not having cholangitis. Now, as we mentioned last time also, patients of cholangiocarcinoma will have, according to Kurvazilla, non-palpable gallbladder. So cholangiocarcinoma at the hilum will not result in palpable gallbladder because the obstruction is occurring to the supracystic bile duct. So that's how we will reach a clinical diagnosis, which will be supported by the ultrasound. Then we'll confirm with the investigation what type of disease, what type of this cholangiocarcinoma patient has. And as we'll come to that, there are various types and we should know what exactly needs to be done. And the next thing is to ascertain resectability. Now, if we find that, okay, there is a patient who's got a lesion in the confluence or in the proximal biliary tract, now, is it resectable? What is that which makes it unresectable? Involvement of the hepatic artery and involvement of the portal vein will generally make it unresectable, because that will mean that you need to resect these structures and then re-anastomose or establish circulation, which is generally in a patient of cancer considered to be a very risky situation. So by and large, if there is involvement of the hepatic artery or there is involvement of the portal vein, this is considered to be unresectable. Again, if there is involvement, this lesion has come out of the duct and is involving structures outside the duct, there's an extra ductal spread. That is again a situation which will make it unresectable. That means, and if there are large lymph nodes other than the lymph nodes present by the bile duct, that is the regional lymph nodes. If there are lymph nodes which are present in the celiac axis or in the in the portocaval region, that will be considered to be unresectable. So by and large, these are the things that we'll have to be looking at and then understand whether we can offer treatment or not. So some patients, by way of their poor Karnofsky scale, or patient having deep jaundice, having ascites or Burkitt's lymph node, we know that it's a metastatic disease, and we can call it inoperable right away. So these are things which we can establish on the basis of our clinical examination and basic investigation. And as I said, resectability will have to be known about those patients which are considered to be operable. If our patient is having good Karnofsky, is active, so we really need to know whether the disease is whether we can achieve an R0 resection or we can't achieve an R0 resection. And in that direction, CECT will give us a triple phase CT scan, will give us a very useful information whether we can remove this cholangiocarcinoma, and what would be the extent of surgery to achieve that R0 resection. Now, this is on the basis of bismuth neckage diamond classification. So you have type 1, which is in the bile duct, which is now you're having a type 2, which is reaching up to the confluence. And here again, you can excise it with a clean margin without having to do anything more than that, and then make a anastomosis between the you have to then make a hepaticojejunostomy both with the right and the left duct. In 3A, the disease is extending now into the uh, right hepatic duct. Now, it may require excision of the bile duct with removal of the right lobe of the liver. Similarly, if the same situation is occurring on the left side, again, it may require this kind of disease would require removal of the left lobe of the liver and the removal of the common bile duct and reconstruction and with the right hepatic duct. So 3A and 3B. And in 4B, now here the disease is going into both the lobes of the liver. So here it could be that if you can achieve an R0 by doing some kind of a central hepatectomy, and then you may need to construct anastomosis between the 4 or 5 ducts, which would be separated by the excision of the duct. So this is the kind of things that you would need to be doing. Generally speaking, there'll be very few patients of cholangiocarcinoma which will reach this stage of assessment and this stage of planning treatment. By and large, most patients will be inoperable. And as I mentioned, the gold standard test for knowing whether the patient is resectable or not resectable is triple phase CT scan. And that will give us a very clear idea about the involvement of the liver, about the extraductal involvement, about the involvement of the portal vein, and about the involvement of the hepatic artery, and also about the involvement of the lymph nodes beyond the first order lymph nodes, which are present along the hepatic duct. So this is again a demonstration of various types of procedures that we need to be doing for these patients. Now, the next entity that we need to know about is CA gallbladder. We suspect CA gallbladder on the basis of ultrasound examination at times. And here we have a patient of obstructive jaundice with a mass in the gallbladder. Now the diagnosis is very clear that this patient has a CA gallbladder which is causing obstruction to the biliary system. The obstruction could be at the level of the junction of the cystic duct with the common hepatic duct, or it could be extension of the disease from the neck of the gallbladder directly to the porta hepatis. Now, neck of the gallbladder is in contact with the right hepatic duct. So if the extension occurs along that path, there would be direct extension to the porta hepatis, or there could be lymph nodal involvement in the porta hepatis. So this is the way CA gallbladder causes obstructive jaundice. You would be lucky if you can diagnose CA gallbladder without obstructive jaundice, because that's the way situation, that's the clinical condition where you can offer or where you can operate for treatment for the cure of the patient. So in the CA gallbladder, if we can diagnose CA gallbladder without obstructive jaundice, that is the only time when we can offer a good cure and good control to the patient. Initially control and then cure. And how do we suspect that on ultrasound? That is, if we find that there is asymmetrical thickening, or there is a diffuse thickening of the gallbladder, or we find a mass lesion within the gallbladder. So these are things which will direct our suspicion towards the possibility of a CA gallbladder when the patient is not having obstructive jaundice. Now, how do we confirm the diagnosis? I think in today's time, confirmation is very conveniently possible with the with the application of endoscopic ultrasound and FNAC. Endoscopic ultrasound per se can give a lot of useful information, and FNA can confirm. So I think FNA can tell us about the state of the gallbladder. FNA can help us take a endoscopic ultrasound can help us know about the state of the gallbladder, about the mass lesion, about the lymph node, and also help us take an FNA. And if an FNA is positive, I think that is something which can be pressed into the algorithm for the treatment. As we mentioned, resectability will require a very good triple phase CT scan to know the extent of the disease into the gallbladder, extent of the disease around the gallbladder, and extent of the disease into the bile duct and the lymph nodes, and any other uh, lymph nodal group in the abdomen. So I think CECT is a must when you are planning surgery. Remember again, CT scan in today's time is generally would be done only when you are looking for a possibility of resection. So a patient with a good performance status, a patient with no pre-op features of inoperability, and then such a patient is subjected to CT scan. And if we find on a CT that the patient is having a resectable disease, that is the next step would be surgery in that patient. Now, I think it's also very important to understand one more point. CECT underestimates the disease. So if the CECT says the disease is resectable, chances are that you may still find the disease unresectable. On the other hand, if CECT tells you that the disease is unresectable, there is very little chance, rather no chance, that you would find the disease to be resectable. Sham,
Yes, sir.
are you with me?
Yes, sir.
Or,
Yes, sir.
or I'm lost in a monologue?
No, sir. No, sir. We are with you,
Anything that you would like to ask, you can note
sir.
down the questions, and at the end, I will answer those questions.
Yes, sir. Definitely, sir.
If you want me to stop it here and take a few questions, I can also do that. Or we can do it at the end.
You can do it in the end, sir.
Okay, fine. So that's all that we need to know about the CA gallbladder. And as far as the clinical case of obstructive jaundice and CA gallbladder is concerned, here you would have a patient with a mass in the gallbladder with obstructive jaundice and may have ascites. So if that is the, and patient may also have simultaneously secondaries in the gallbladder. So generally that is the type of case that you will get in your exam. And that would mean probably that this patient is past beyond any kind of cure. Now, CA head of the pancreas, and I think clinical situation should be well understood. That is a patient who is in the cancer age group, is having progressive jaundice, and stools are now become clay colored, urine is high colored. Generally, patient will not have any cholangitis, and patient will be generally having, a discomfort in the epigastrium, and sometimes the discomfort is in the later part of the disease when the disease has advanced so much that the patient has to sit down or sit in such a hunched up position, bent forward to get some pain relief. And that's because, when there is some kind of a falling off of the pancreas from the peripancreatic plexus, patient may receive some pain relief. But that's an advanced presentation. Also, please understand that CA head of the pancreas is considered to be an important cause of painless obstructive jaundice. Well, that is not the case always. Head of the pancreas is generally associated with some pain, and this pain occurs early in the course, unlike periampullary cancer. Now, ultrasound will give you a very useful information. And what useful information you'll get from the ultrasound? Ultrasound will show you that the gallbladder is distended. So that is the ultrasound equivalent of the Courvoisier's sign. That ultrasound shows that gallbladder is distended. The common hepatic duct is dilated, right? and intrahepatic biliary channels are dilated, and there is a mass in the head of the pancreas. So that's the kind of a picture that you will have from the ultrasound. It may show other things like lymph nodes and ascites also, but these are things which may also be present. Now, how would you confirm your diagnosis? Confirmed with EUS and FNA. But again, this is one situation where you do not require a confirmation. If everything is falling in place, then you can go in for the treatment depending upon the information available. Now, again, I'm telling you, it is not necessary to confirm the diagnosis that the patient is having CA head pancreas. It is radiological picture and the clinical picture. If they are in consonance, then you can go ahead and plan the treatment. And for planning the treatment and knowing resectability, CECT, triple phase CECT, and endoscopic ultrasound come in handy. So the message that I want to give you here, which should be absolutely clearly understood, that is FNA and histological diagnosis doesn't need to be established in a patient of CA head pancreas. However, if you are doing an endoscopic ultrasound to understand about the resectability of the lesion, you may have a situation where you can take a FNA, but then again, if FNA has not picked up cancer, it is not that you will not offer the standard treatment of resection and cure for resection to this patient. So again, histological confirmation is not required if you are doing a Whipple's operation in CA head pancreas if other criteria of resectability are met, and clinically and ultrasonologically you have a patient where you have confirmed the diagnosis and you have got another leg up from the endoscopic ultrasound. And as you know, for the treatment of the head of the pancreas, when all the criteria are met, so that means the patient is operable, patient is not having lymph nodes beyond the some lymph node in the head of the in the region of the head of the pancreas, and there are no mets in the liver, and there are no other lymph nodal masses anywhere. There is no ascites, and most of all, portal vein and superior mesenteric artery are not involved. So when all these criteria are met, then you have a situation which has been cleared for treatment of CA head pancreas, and the treatment here is Whipple's or a modification of Whipple's, which is called pylorus preserving resection. Pylorus preserving resection is not meant for head of the pancreas. That's meant for its sister lesion, which we are now coming to. Uh, Hello.
Yes, sir.
I don't know why my slides are not moving. What should
Sir,
I?
you can just press and then again try, sir.
Yeah, stop sharing.
No, just press escape button and again you can try.
Okay. Escape button. Uh-huh.
Come in.
No.
Or you
Do
can
you have?
stop sharing and you can reshare it again, sir.
I think that we do that. Stop share now, and then we will go for sharing again. Share the screen. Okay. But now see. Okay, right. Not moving, Sham.
Sir, can you move to this full screen view in the PowerPoint and then try, sir?
Let me do it again. Mm, Share. Okay, I'll just do it.
Scroll it.
Okay, now yeah. The next entity, that is periampullary carcinoma. And what is the difference between the periampullary carcinoma and the head of the pancreas? The difference is in the nature of presentation would be pain is very less in this situation. Hardly, this is one entity where the patient is generally having painless progressive jaundice. And at times, patient can have cholangitis because this lesion has a tendency to go for sloughing. And when the sloughing happens, the lumen gets restored partially, and then the patient can have, some relief in jaundice, but he doesn't become totally anecdotic. So that's the one change. And patient can have some evidence of melena, or what is known as coppery silver stool. Copper is comes from the blood, and silver is because of the nature of the stools, which have become clay color. So that's here. Patient is generally well preserved in the situation. And why the patient is generally well preserved? Because the lesion occurs in the pathway of biliary discharge, and therefore, whenever there is a small obstruction, the jaundice is first to appear. So because of that, the location of the lesion, since it is in the pathway of biliary drainage, and any obstruction will result in occurrence of bilirubinemia, and that's why these lesions tend to declare themselves early and at an early stage also, where they can be subjected to resection. And ultrasound again in this situation will give us picture. This periampullary cancer is generally in the ampulla and within 2 centimeter of the ampulla of water. So any lesion that is occurring in that region is known as periampullary carcinoma, whether it is ampullary, whether it is arising from the pancreatic duct, or from the biliary duct, or from the duodenal mucosa. So any of these lesions would be called as periampullary carcinoma, and it's occurring within 2 centimeter of the opening. Ultrasound, how is the ultrasound of this condition different from the carcinoma head of the pancreas? The ultrasound will show, of course, dilatation of the common bile duct, common hepatic duct, and intrahepatic biliary channels. There will be no mass or very indistinct impression of a small lesion in the head of the pancreas. And at times, we may be able to see a lesion in the region of the papilla of water, and that could be a lesion like a polyp projecting into the second part of the duodenum. So that could be the presentation in this situation. Uh, in this situation, very important information we get is from upper GI endoscopy and biopsy of the lesion which is presenting at the papilla. So that is in a periampullary cancer. Once ultrasound has given us a possibility of a periampullary cancer, the next thing to do in this patient is upper GI endoscopy with a side viewing endoscope and taking a biopsy. So that's the lesion. That sets the stage for confirmation of the disease. And then the next step is how do we know about the resectability? As again, a triple phase CECT is the standard of care when we have decided that the patient has a disease which can be operated. And when a patient has a disease which can be operated, the next thing we have to determine is whether it is resectable. And the criteria of resectability, I have already told you. The criteria are similar, absolutely, and that would be that both portal vein and the supermesenteric artery are not involved for you. Of course, advanced centers, they are now doing even those operations where they sort of either remove a part of the portal vein or superior mesenteric vein and reconstruct. So these are the things which can be done in the advanced center. But for all your need, any lesion which is involving portal vein and superior mesenteric artery is unresectable. And if the disease, of course, causing involvement outside into the retroperitoneum, again, it is unresectable disease. And if the disease is spread to the lymph nodes beyond the first order lymph nodes, and first order lymph nodes are just peripancreatic along the head of the pancreas. And don't forget that involvement of the lymph nodes in pancreatic tumor uh, badly affects the prognosis. But all palpable lymph nodes may not be involved lymph nodes. So when you remove the lesions, you will of course know the histology of the lymph nodes, whether they were reactive lymph nodes or they were involved lymph nodes. So that is what you would do for periampullary carcinoma, and you should be always able to differentiate between the two entities, at least for the discussion's sake, and accordingly plan for the further management. As we were discussing about the treatment, Whipple's operation, which is pancreaticodenectomy, and the other is pylorus preserving pancreaticodenectomy. So in periampullary cases, in some situations, this pylorus preserving pancreaticodenectomy can be applied, and this is supposed to be a superior operation in some regions, and it has a similar disease control, and patients digestive functions are better preserved. But one flip side of this operation is that patient can have a delayed gastric emptying, and which can mar the overall recovery of function. So that's about periampullary carcinoma. So this was the broad subject that we wanted to cover. What do we need to understand about the various conditions which give rise to obstructive jaundice, and how to go about investigating them, and how to make a plan for their treatment. So that was the basic purpose of this presentation, and I hope that we have achieved that purpose. I'd be very happy to answer any queries or questions that you may have in your mind. Over to you.
Uh, yes, sir. Sir, shall I ask a few questions, sir?
Yeah, please do ask questions.
So for FNAC and histology, you told it is not needed for head of pancreas. Sir, regarding cholangiocarcinoma and CA gallbladder, is it needed, sir? Histological diagnosis, or is this CT scan is more than?
You see, you have understood that as far as the head of the pancreas is concerned, you will be guided by the clinical context and the imaging results,
Yes, sir.
right?
Yes.
So that you have patient of CA head of the pancreas. So you've done you taken a good history, then you have done an ultrasound, and then you know that okay, my patient has a mass in the gallbladder. So you do a CT scan, and in a patient uh, who is a candidate for surgery, you would do a CT scan and know the overall ramification of the disease, overall extent of the disease, and plan the treatment accordingly. There is no need to prove the diagnosis. No need to histologically prove the diagnosis. The clinical context and imaging findings together will be pressed into the service, and then the treatment will be formulated. However, if we find that we are not going to do any surgery in these patients, and the patient may require some kind of a palliation, in whenever you're giving palliation by way of chemo or by way of radiation, you have to have a histological proof of disease, right? So one of the very important condition, that we need to really understand is, a mass due to chronic pancreatitis. A mass due to chronic pancreatitis can be uh, a significant entity with which the diagnosis can be confused. So if there is such a situation, we then need to have a proper histological diagnosis, then only we can move forward. Okay, so in this North India, we don't have many cases of head pancreas mass due to pancreatitis, chronic calcific pancreatitis. But in South, especially in Kerala, they have patients where there is, mass due to head of this chronic calcific pancreatitis. So in these entities, you would definitely need to prove your diagnosis. However, in a patient of obstructive jaundice, who's got a good performance status, and if even if this mass is because of calcific pancreatitis, treatment by way of Whipple's operation is still is a good therapeutic modality to control and cure the disease. Now you were talking about a lesion in the hilum, right?
Yes, sir.
If a patient has Klatskin tumor, if the patient has a mass lesion in the mid CBD, no, do we need to uh,
Have
confirm
FNAC.
diagnosis. Generally, you would do a brush cytology of these lesions and to see if there are malignant cells are present or not. But overall, CT scan will be the final arbiter of the diagnosis. That if you get, a brush cytology positive, that's fine. You have confirmed the diagnosis preoperatively. But if you do not find that, that doesn't mean that the cancer is not present. And therefore, you will treat the patient on the basis of the clinical picture, ultrasound, and the radiological imaging finding. So these are the findings which will tell you if there is a mass lesion in the hilum of the in the confluence of the bile duct, or if there is a mass lesion in the bile duct. So for sure, these are the conditions which are because of only cholangiocarcinoma, and then you will treat it accordingly. But you will preoperatively make an attempt to do a brush cytology of these lesions and get the diagnosis. Does that answer your question?
Yes, sir.
Okay.
Sir, there's a question in the chat box. There is a lot of delay in the today's OPD to get FNAC diagnosis. Can't we start chemotherapy in a CT diagnosed in a periampere carcinoma? Sir?
Never.
Never.
Radiologist and radiation specialist and oncologist will never agree to give any kind of chemo slash radiation in these patients till you prove it, right? And as it is, one should be very clear. What do we achieve by way of doing palliation with either radiation or with chemotherapy? Are these very significant modalities to cause some very significant shrinkage of these tumors? I mean, all these tumors, whether they are arising from the gallbladder mucosa or whether they are arising from pancreas, they are considered to be radio resistant, and they're also considered to be very poor responder to chemotherapy. So therefore, what do we gain out of these, modalities being used for palliation? There are some studies which have shown that maybe giving chemotherapy preoperatively may have some role in neoadjuvant setting. But then again, you can only apply these modalities for even in the neoadjuvant setting when your diagnosis is very clear. And in this situation, whenever you are giving neoadjuvant chemotherapy, chemotherapy, or whenever you are giving radiation as a palliation or as neoadjuvant form of treatment, the clinical diagnosis has to be beyond the shadow of doubt. And that means histology has to be positive. Uh,
Yes, sir.
One important point that I want to mention here is this, that palliation should not be applied in an asymptomatic patient. Palliation is only done in those patients who are having some intractable symptoms which are affecting their quality of life, and some good modality exists to help that situation. Now, for example, our patients of obstructive jaundice, what kind of an intractable symptom that they can have which would affect their quality of life adversely? That is itching. Now, patient is not able to sleep because he's having itching all the time. Now, we know that if we can do some kind of a biliary drainage, this patient can improve overnight. So, yes, we will do this biliary drainage by way of stenting or by PTBD to reduce his jaundice, and his problems will get better, right? So that is the way, you look at when you are talking about palliation. If a patient is having a jaundice of 20 and is not having any significant um, itching, we don't need to bother about that, because ultimately, he's got an advanced disease, he's going to die of his disease. So it's not simply that we will do a palliation because, some modality exists. Palliation in only those situations where there are intractable symptoms which are making patient's life miserable. And another situation will be cholangitis. For example, the patient is having cholangitis and having sepsis and high grade fever, and we know that we can help this patient by way of doing some kind of a biliary drainage procedure, then why not? But if the patient is having jaundice patient is having poor appetite, and patient is becoming lethargic, we know that, okay, he's reaching the end of his life, and therefore we should just, provide him an honorable exit rather than giving him an exit through the operation theater or endoscopic suite. Got the point?
Yes, sir.
Another point that should be also important in this discussion when we talk about palliation. Palliation should be done by uh, non-invasive or minimally invasive methods. Palliation should not be done by any surgical method which is highly risky and likely to cause patients death. Now, what is that I have in mind? Like, for example, if I say that, okay, I have a patient of obstructive jaundice and he has got a mass in the hilum, and we can plan and do a surgical bypass. And surgical bypass will be in the nature of either segment 3 bypass or maybe in the nature of left hepatico-jejunostomy. Should we do it? Never. If preoperatively we know that the disease is unresectable, we will never like to do any bypass surgically. These patients are only amenable to bypass by endoscopic method. Okay. Only exception is when I am operating on a patient and I find that I can't remove it. And that's the time, I am permitted to do a surgical bypass operation, not otherwise. So the message that I want to give you here is that surgical bypass is not a planned thing, but can be done only in those patients where you have operated that patient for a curative resection and you find that the disease is unresectable. You got my point?
Yes, sir.
Okay. Anything else?
Sir, one last, sir. In any CA gallbladder with obstructive jaundice, sir, even I mean to even just before even if it is resectable tumor, if the patient is having a severe obstructive jaundice, should we drain it and then do the necessary step, or you can directly go for the surgery, sir?
You see, as we were talking about CA gallbladder, and CA gallbladder with obstructive jaundice means that the disease will be an advanced disease. Why? Because either the disease is, spread, either the disease has spread to the hilum of the gallbladder, hilum of the liver, as I mentioned, that this neck of the gallbladder is in contact of the right hepatic duct and right side of the common hepatic duct. So if the disease has directly affected there, right, that's why how a patient of CA gallbladder develops obstructive jaundice. When the disease spreads to the hilum of the liver, that's number one. And how does it spread to the hilum of the liver? I've just given you an example. Second is when the disease spreads along the neck of the gallbladder to the common hepatic duct and the common bile duct. So that is direct extension. And third is when the lymph nodes in the common hepatic duct, in the periductal region, and this lymphatic spread may happen in the retrograde direction to the porta hepatis. So these are the three ways by which patient develops obstructive jaundice in the CA gallbladder. So it's very rare to have a patient of obstructive jaundice with CA gallbladder, which will be at an early stage of carcinoma gallbladder and where the disease, local disease, would be resectable. Right. So it's only those patients who have been diagnosed with an ultrasound that you would be able to give them significant control and cure of their disease by way of excision when CA gallbladder presents with without obstructive jaundice. When CA gallbladder presents with obstructive jaundice, it's already an advanced disease. I think it should be clear.
Yes, sir.
So I think we just call it a day here, and I would definitely be happy to have your inputs and also